Welcome to the Power of Prevention podcast, where you learn small chunks of prevention tips for people who want to live a healthy life while achieving more. I am your coach, Amax Chike. The question for today: how do you make sense of all the drugs and recommendations out there for COVID-19 prevention and treatment? Now, this is a special episode for COVID-19 treatment and to celebrate the launch of my brand new book, The Power of Prevention, focused on using prevention intelligence and the habits of prevention to achieve health, wealth, and happiness. Visit powersofprevention.com to grab your copy today. A lot of what I'm going to talk about today is out of guidelines from reputable authorities for the treatment of COVID-19, which I have termed the race for COVID-19 therapeutics and cure. Why am I putting up this podcast now, dedicating it to COVID-19? It's because of four main facts. Number one, there is panic purchase on the rise. People are buying up and stocking up all kinds of medications based on what they hear from all sources. And every day you log online, a new therapy is proposed. Most people are also listening to the news media and the press and sometimes some government officials to get their information about what they should do at this time instead of getting credible information from their healthcare professionals. What's alarming is this, though. The safety profile of most of the therapies that is being touted or being presented is not known as in relation to COVID-19 and how it works in the body. Now, this presentation is going to be in two parts. The first part will talk about all the guidelines we have till date, while the second part will talk about the drug chloroquine or hydroxychloroquine. Let's get a brief overview again about COVID-19. COVID-19 is caused by coronavirus called SARS-CoV-2. Who is most vulnerable? The older people and people who have severe underlying medical conditions like heart or lung diseases or diabetes. As of today, COVID-19 has killed over 240,000 people worldwide, with 3.4 million people infections confirmed. Over 1 million people have recovered, which is very good news. How is COVID-19 transmitted? Majorly from person to person, from respiratory droplets, or when an infected person coughs or sneezes or even talks. It's also unique because you can also get COVID-19 just by touching surfaces that someone else who is infected has touched and left a residue of the virus on that surface. It has been proposed that these viruses can last as long as 6 hours on surfaces. How do we prevent COVID-19? This is the most crucial part of the presentation, is the shortest part. The prevention pharmacist has come up with a SMART acronym that will help you remember. SMART means S, stay at home if you're sick. Mask up to protect others. A in SMART says stay apart from people at least 6 feet apart. The R in SMART says routinely wash your hand as often as possible. And if you cannot wash your hand or unable to do so, use an alcohol-based sanitizer, at least 60 to 65% and up. The T in SMART stands for touchless. Don't touch your body, open parts of your body or your face with unclean hands. Now that we've talked about COVID-19, a brief overview, let's also talk about some of the symptoms of COVID-19, things you should watch out for. The first one is fever. You are very tired. You have this dry cough that is just irritating and won't go away. You have shortness of breath or difficulty breathing. You have chills, you have muscle pain, you have a headache, you have sore throat. Also, there is this new loss of taste or smell. There are also other severe symptoms to watch out for. Symptoms like if you have trouble breathing, if you have persistent pain or pressure in the chest or on the chest, if you have a new onset of confusion or inability to arouse, if you have bluish lips or face. These are very serious symptoms, and if you have any of these severe symptoms, trouble breathing, persistent pain or pressure in the chest, confusion or bluish lips or face, please call your healthcare provider immediately or call 911. Now, let's dive into the therapeutics or recommendation that's out there for COVID-19. As of today, we have a long list, which the sources from American Society of Health System Pharmacists. It's divided into 3 categories. Number 1, antiviral agents. Number 2, supporting agents, and other medications that is used. The first category of drugs I would like to talk about is the antiviral agents. The first one on that list is a drug called baloxavir. It is active against influenza virus. Currently, there is no known published clinical trial or data regarding efficacy or safety in the treatment of COVID-19. The second drug I would like to talk about is chloroquine sulfate. And because I'm taking chloroquine in full detail in the second part of this presentation, it will suffice just to know that it's an anti-malaria. It also has antiviral properties. It also is an anti-amoebicidal. So also there is limited clinical data available to date to evaluate the use of chloroquine for treatment or prevention of COVID-19. Let's just leave it at that while we explore the other options. The third drug I would like to talk about is favipiravir, whose brand name is Avigen. Avigen is also an antiviral. It is actually a broad-spectrum antiviral drug with in vitro activity against a lot of viruses, including the coronaviruses. Now, when we say in vitro activity, that means it's been shown to be effective outside the body, but inside the test tube. We have only very limited data available to date to evaluate the use of favipiravir in the treatment of COVID-19. Even though it has this in vitro activity against coronaviruses outside the body in vitro, its effect inside the body has not been studied well. The next antiviral I would like to talk about is a combination drug called lopinavir and Ritanavir. The brand name is Calitra. It is an HIV protease inhibitor. Why did it make the list? What is the rationale? It is an antiretroviral drug with in vitro activity against SARS-CoV and MERS-CoV. There's been some evidence in animal studies, but so far, no evidence in human studies. So efficacy for using it for treatment of COVID-19 is not definitely established. We need additional study to be able to do that. Another drug is a popular drug that we use for flu, which is called oseltamivir or Tamiflu. Tamiflu has, of course, antiviral activities against influenza virus. However, we have no data to support use of Tamiflu in the treatment of COVID-19. One more drug that is being looked at for the potential treatment of COVID-19, this SARS-CoV-2 virus, is an antiviral called Remdesivir. It's a broad-spectrum antiviral, and it does have activity against coronaviruses. As of today, actually, FDA issued emergency use authorizations for investigational antiviral called Remdesivir for the treatment of lab-tested and confirmed cases of COVID-19 in hospitalized adults and children. Remember, it is still an investigational drug, but this drug has been shown to have efficacy or shorten the time of recovery in some patients. Now, the key words to note in this emergency use authorization issued by FDA are the emergency use, and number 2 is in hospitals. That means we usually give it IV and is administered by healthcare providers. It's recommended for use in adults and children. It's specifically for severe diseases and lab-confirmed cases. Now, here's what to watch out. The broad-spectrum antiviral against the MERS and SARS coronaviruses was initially developed. Remdesivir was developed to treat Ebola and Marburg viruses, and they were found to be very ineffective. The common side effects of Remdesivir are respiratory failure. It also causes, elevates blood biomarkers of organ failure, like when you have low potassium, low albumin, low blood count, and yellow discoloration of skin. There is a very serious drug-drug interaction associated with Remdesivir use, which is it increases abnormal heart rhythm. So it is absolutely contraindicated in use with hydroxychloroquine. And this is especially important because in most hospitalized patients, one of the drugs that we use to manage therapy or patients with confirmed cases is hydroxychloroquine. It's very important that we don't combine it with Remdesivir. Under the antivirals, we also have another drug we call Umifenovir or Arbidol. Arbidol is also an antiviral, of course. It has broad spectrum antiviral activity in vitro against a lot of viruses, including the coronaviruses. It's actually not commercially available in the United States. Now, having talked about a couple of antivirals that are available, now let's dive into some supporting agents. These are drugs that are not totally antivirals, but they do other things to support the symptoms associated with COVID-19 or SARS-CoV-2 infection. The first one I'd like to talk about is the one we call Anakinra. It's a disease-modifying anti-rheumatic drug. Now, Anakinra has no data to date to support its use in the treatment of COVID-19. Why is it even being considered? Why did it make the recommendation list? Number one, it is used in humans with severe cytokine release syndrome, which so it was theorized to have some effective effect in modifying some of the symptoms of COVID-19, but none was proved to be effective currently. We don't have any published clinical trials or evidence supporting its efficacy or safety in treatment of COVID-19. Now, one popular drug that's actually over the counter that has been proposed for use with COVID in prevention and also treatment of patients actively infected with COVID-19 is ascorbic acid. It comes in tablet form. We also have high doses in IV form in the hospital. Ascorbic acid is vitamin C. Why is it being recommended? It is an antioxidant, as we all know. It's also a cofactor for numerous physiologic reactions. It may support host defense against infections and protect host cells against infection-induced oxidative stress. It is used for common cold. The effect of oral supplementation of vitamin C. Some people take up to 2,000 milligrams per dose or more, have been seen to decrease durations of symptoms. It has decreased incidence of common cold in individuals under heavy physical stress, but not in overall population. Now, current data does not specifically back up the effect of vitamin C to COVID-19. We don't have any current data, and we don't have any current studies specifically for COVID-19. Vitamin C is also one of the drugs I will go into detail in one of my next presentations when we're talking about other over-the-counter recommendations. Another drug that has made the list of recommendations is Azithromycin. The brand name that we popularly know is the Z-Pak. It's a macrolide antibiotic. It has antibacterial with some in vitro activity against some viruses like influenza and H1N1 and Zika virus. There is no data to date on in vitro activity against coronaviruses, including SARS-CoV-2. However, azithromycin has this anti-inflammatory effect. It has effects on pro-inflammatory cytokines. While we don't understand the full mechanism of this action, that's actually where its rationale for use makes sense. It's anti-immunomodulatory and anti-inflammatory effect. As far as COVID-19, current data is insufficient to establish the advantages and disadvantages of using azithromycin in management of COVID-19. I like to highlight here while we're talking about azithromycin that both azithromycin and chloroquine or hydroxychloroquine are associated with abnormal heart rhythm, which they cause QT prolongation. So caution is advised if you're considering use of both drugs in patients at risk for QT prolongation or receiving other drugs associated with arrhythmias, and in those with chronic medical conditions like people who have renal failure, people who have things like hepatic disease. Diagnostic testing and monitoring is recommended to minimize the effect or the risk of drug-induced cardiac effects. So, azithromycin combined with hydroxychloroquine is one of the popular combo or prescriptions we normally get to fill. Remember, if you have a pre-existing heart condition or you have an organ failure like renal or hepatic disease, additional monitoring is definitely needed. The next set of drug is corticosteroids. Of course, we all know that corticosteroids are potent anti-inflammatory and anti-fibrotic drugs. Up to date, we don't have any evidence that is conclusive to advise to the use of corticosteroids in the treatment of COVID-19 patients. As a matter of fact, World Health Organization and CDC recommend that steroids not be routinely used in patients with COVID-19 unless indicated for another reason, like the patient is asthmatic, has COPD exacerbation, refractory septic shock, and then if they're already on steroids, you continue. One main reason why this is strongly advised against as an initial treatment in patients with COVID-19 is that steroids can actually inhibit immune response, reduce pathogen clearance, while at the same time increasing viral shedding. So based on limited information from observational studies done so far with methylprednisolone, it is recommended that steroids are not put in as the drug of choice or first set of therapeutics unless patient is already being treated with steroids for other reasons. Another supporting agent is Epoprostenol. It is an inhaled agent. It is a vasodilating agent, which we commonly use for PAH, which is pulmonary arterial hypertension. It has proven very useful as an adjunct treatment for acute respiratory distress syndrome, which we call ARBs, a potential complication of COVID-19. However, additional studies are needed to evaluate the potential role of inhaled epoprostenol in the treatment of COVID-19. Now, the next drug that is being promoted for COVID-19 is an inhaled agent we call it nitric oxide. Nitric oxide is a vasodilating agent. It is used to treat failing lungs. It also has been found to have antiviral activity against coronavirus. It is, how does it work? The rationale for its selection. It is actually a selective pulmonary vasodilator. It may be useful in treating the ARDS, which is acute respiratory distress syndrome, a potential complication of COVID-19. At this point, we don't have any clinical studies evaluating use specifically in COVID-19 patients. Another supporting agent for the treatment of COVID-19 is a drug we call Kefzera. The chemical name is Sirolimus. Again, is an anti-rheumatic drug, a disease-modifying anti-rheumatic drug. Currently, there is no non-published clinical trial or evidence supporting efficacy or safety against coronaviruses. The next one is Sirolimus. Sirolimus is an immunosuppressive agent. In studies outside the body, like test tube studies, it has demonstrated inhibitory activity against MERS-CoV infection. There's possible clinical application of Sirolimus. However, we don't have specific data to COVID-19, nCoV, or SARS-CoV-2. Additional studies are needed. Another drug that's made the recommendation list is Tocilizumab, which is actemra. Actemra is a disease-modifying anti-rheumatic drug. It is used in patients as an antibody, is a humanized monoclonal antibody specific for interleukin-6 receptor. It has been shown that it may potentially combat cytokine release syndrome, which is CRS, symptoms in severely ill COVID-19 patients, which is very useful. However, patients with severe COVID-19 infection demonstrated rapid fever reduction and the reduced need for supplemental oxygen within several days after receiving Tocilizumab. Actemra was initially given as a single 400 milligram dose by IV infusion. and this dose was repeated within 12 hours. This drug is routinely used in China to treat severely or critically ill COVID-19 patients with extensive lung lesions and high interleukin 6 levels. We don't have any confirmed studies in the United States to back its use. Now, let's talk about other supporting agents. And most of these supporting agents are drugs we're familiar with and have proven one way or the other to help support patients with COVID-19, treat some of the symptoms and make them feel better. The first on the list is ACE inhibitors, which is angiotensin converting enzyme inhibitors, and also the angiotensin receptor blockers, angiotensin 2 receptor blockers. Now, an ACE inhibitor has been found to help patients with severe COVID-19 infections. It has what we call hypothetical harm and hypothetical benefit. And that explains why it's made the list of treatment recommendations for COVID-19 or treatment guidelines for COVID-19. Now, we remember that the ACE2 receptor in the lungs is what the coronavirus is used to enter the cells. They have this special ability, SARS-CoV-2 virus have this special ability to bind to this special protein on human cells called ACE2, and we have a lot of ACE2 receptors on the lungs. Now, the hypothetical benefit of ACE inhibitors or angiotensin 2 receptor blockers, which we call ARBs, is that they may have a protective effect against lung damage, or they may have a paradoxical effect in terms of virus binding. Now, the hypothetical harm, which is also possible, is that human pathogenic coronaviruses bind to their target through this ACE2 enzyme we've just talked about. The expression of ACE2 may be increased in patients with ACE2 inhibitors or ARBs. Increased expression of these receptors, the ACE2 receptors, may potentially facilitate COVID-19 infections. In between these two potential benefits and harm, we're looking at the risk-benefit analysis. And the recommendation that came from American Heart Association, American College of Cardiology, Heart Failure Society of America, European Society of Cardiology, is that you have to continue treatment with renin-angiotensin-aldosterone system antagonist. That's the ACE and the ARBs in those patients who are currently prescribed such agents, because patients that has cardiovascular diseases are at an increased risk of COVID-19 infections. In other words, if the patient was already on ACE, like lisinopril, or ARBs, like losartan, the recommendation is that they continue treatment. And because abrupt withdrawal of any of the ACE or the ARBs inhibitors in high-risk patients, like patients with heart failure, patients with prior myocardial infarction, may actually lead to clinical instability and adverse health outcome. So ACE is very beneficial. There's also some potential harm. It's just to weigh the risk-benefit analysis. But the recommendations from the body says if the patient is already on it, keep the patient on it. Because at that point, the risk the benefits outweighs the risk. Another drug that is used as a supporting agent is ibuprofen. Some of the brand names is Motrin. It's a non-steroidal anti-inflammatory agent. There has been speculations about the link between ibuprofen and increased 2 expression, leading to worse outcomes in COVID-19 patients. And there's been news out there that they should not be used in patients with COVID-19. We don't have any trials or clinical experience to back up this speculation. As a matter of fact, a letter published, a statement attributed to World Health Organization spokesperson Christian Lindmeier recommending paracetamol and avoiding ibuprofen as a self-medication was widely circulated in the media. However, such a position has not been found on any World Health Organization website or any other official sources. World Health Organization has stated that after a rapid review of literature, it is not aware of published clinical or population-based data on this topic. As of middle of March, via Twitter, WHO says they do not recommend against the use of ibuprofen. So again, ibuprofen is over the counter, is a risk-benefit analysis. The speculation is that it could worsen outcome for COVID-19 patients. It's some decision you have to make with your doctor or your healthcare professional. Another supporting agent is indomethacin. Is another non-steroidal anti-inflammatory agent. It has been shown to have possible antiviral activity against other coronaviruses like SARS-CoV or canine cove. How it does that is that it has been said to interfere with viral RNA synthesis. Most of the study or trial or clinical experience so far with indomethacin has been more speculative, with very few documentations and very low level of evidence. Another drug is ivermectin, which is an antihelmintic, which we use to prevent worms in animals. It has been shown to show in vitro activity against some human and animal viruses. The in vitro evidence of activity against SARS-CoV-2 in viral Haslam cells infected with the virus. However, we don't have any data to support the use in treatment of COVID-19. The only data we're seeing so far comes from as a result of one single in vitro study that was done in a test tube outside the body. There are no published data regarding the efficacy of ivermectin or safety in the treatment of COVID-19. We also have a few more drugs that's under the other agents. One is nebulized drugs. Why are we recommending nebulized drugs? Why it's been added to this list? It's because of the one concern for potential harm. It has been theorized that the use of nebulized drugs like albuterol for the management of respiratory conditions in patients with COVID-19 may actually distribute the virus into the air and expose close contacts. Nebulizer treatments in clinical practice to treat influenza and other respiratory infections has been shown to generate droplets or aerosols. So the recommendation to contain this potential harm, according to American College of Allergy, Asthma and Immunology, is that nebulized albuterol should be administered in a location that minimizes exposure to close contacts who do not have COVID-19 infection. If the person is at home, they should choose a location for nebulization where air is not recirculated, like the porch. They can go out in the patio or even go to the garage. Or they can also be in a place where surfaces can be cleaned easily and may not need cleaning. However, if the patient is hospitalized, clinicians typically use nebulizers to deliver medications in hospitals, just like albuterol. But ACAI is encouraging clinicians to use metered dose inhalers to reduce the risk of virus becoming airborne when treating patients infected with COVID-19. Another supporting agent is niclosamide, which is an antihelmintic also. It's a broad-spectrum antiviral drug. It has been shown to have in vitro activity against SARS-CoV and MERS-CoV. The clinical experience, currently there is no known published clinical trial data regarding efficacy or safety in the treatment of COVID-19. Another agent in the other list is nitazoxanide, which is an antiprotozoal. It has in vitro activity against various viruses, including coronaviruses, and that's why it made the list. Again, currently we have no known published clinical trials or data regarding efficacy or safety in the treatment of COVID-19. In summary, COVID-19 therapeutics, or the race for COVID-19 cure and prevention, has been something that we have very limited clinical experience on. Most of the drugs that's being recommended are still on the emergency use evaluations. The outlook on a vaccine to prevent COVID-19 is still a little far down the road. And another thing is that most of the drugs have established side effects that we need to watch out for, especially drug-induced diseases. You have to weigh the benefit versus the risk with your healthcare provider. Be clear about why you're using it and what studies has been done to support its use. Be clear about how it can help you instead of harming you further. And stand firm on preventing COVID-19 from infecting you in the first place. And that's it for today. Thank you for being patient and listening to the whole process, to the whole list of therapies. Next podcast for COVID-19 will be dedicated to specific drugs, will be shorter and much quicker. And also we'll do a lot more on looking at the over-the-counter drugs, which most people can lay their hands on so that they can make informed decisions and choose the right ones. I thank you again for watching. Please don't forget to click the subscribe button below. And most importantly, don't forget to check out powersofprevention.com and pre-order your book, The Power of Prevention. Think prevention, save lives. Thank you so much.